Hello there, students. Today we're going to be talking about seizures. Now, your first seizure experience may be at a time and a location where you least are expecting it. I will say for myself and this one student I'm about to share with you, it was a typical average lecture day. For me, I usually lecture and then I go to the cafeteria and grab a bite and then I head back to my office. On this particular day, I had a student waiting for me in the lobby. She jumps up as soon as I come in and she's like, "Miss Tonis, you were right." I said, "Of course I am." Okay, actually, I totally did not say that, but if it were more socially appropriate to be bold about how you own your craft, I completely would have said that. Anyway, I actually said to her, "Okay, about what?" She said, "You are right about the seizures that you lectured on today." So she begins to tell me about the story of what happened to her, and I'm going to do my best to try to tell it from her point of view. So here she goes. She says, "I was walking back to my car, which is parked by the tennis courts when I go home, but there in the median grassy area was a girl who was laying face down with her stuff, like in papers, all spread out next to her. She said that nobody was walking up to her, no one stopped to help her or did anything. They just kind of kept going where they were supposed to go." She mentioned that I walked up to her and I asked her, like, "Hey, are you okay?" She tapped her on the shoulder. The girl didn't say anything. She started like kind of shaking her shoulder. She ended up rolling her over, and then she noticed that the girl had her eyes rolled back in her head and that she was drooling. I asked, of course, was she breathing and have a pulse? And, the student said yes. And so anyway, then my student reported that another girl actually came to help and to see what was going on. And together they were able to get the girl to sit up. But as they did it, they noticed that the girl had accidentally urinated on herself. And they said about 10 minutes later, the girl slowly began coming around, and then they had asked her if she knew what happened, and the girl unfortunately had no idea, but she did say, "Okay, I have seizures, and my doctor just recently switched me to a new medication to see if we could get them under control." Embarrassed, she explained that the old medicine wasn't working anymore, and she was having more and more seizures, and that was probably due to a tolerance, but she has since she can remember always had grand mal seizures, which means that she blacks out and doesn't know like what happens until like 30 minutes later. I ended up asking the student if the girl had intentions to drive home, which would not be a good idea. And she said she did ask the girl if she could help with transportation. Apparently, the girl had her driver's license revoked because of her epilepsy and is totally dependent on public transportation, her friends, and her parents. Whoa, the student was like, "Never in a million years would I have thought like that you lecture on something like this and then I go and experience it." Now, FYI, I have had lots of patients with history of seizures, and their seizures are under control, and if let me back it up. If their seizures are under control, they can actually obtain a driver's license. If they are not under control, which is defined as being seizure-free for up to 2 years, then they can't get a license. There is a lot of ifs, ands, and buts to this law about epilepsy and driving. You would honestly need to, pull it up and read it for yourself to get all the details. Epilepsy.com and search driving laws. Okay. Now, on that story, I actually had a patient who had a significant history for drug-resistant seizures, and as him and I were chatting it up, he mentioned driving. I asked him, well, how did you get a driver's license? And he reported that he had not had a driver's license in years. What's a nurse to do in this situation? Do you report it to the police? Nope, can't. Do you report it to the doctor? Yes, we are going to report it to the doctor and social services. This team of individuals can provide extensive education to this patient and hope that he'll access other resources for transportation. Do I personally think my patient will stop driving? No, not to say in the least. But who knows, maybe it's the 70th person who talks to him that he will understand he's not supposed to be behind the wheel. Okay, let's begin talking about seizures, and FYI, all of these pictures that I have shown you on this slide are not the actual patients, so I just borrowed them from a clever search term Google search, so yeah, don't judge me. I didn't actually take pictures of these people. That would be probably illegal. Okay, now for what all of you have been waiting for, the seizure disorder lecture. Seizures are sudden and excessive abnormal electrical discharges from cerebral neurons. This is going to result in motor and sensory changes and behavior changes. Some of the characteristics of seizures include like a loss of consciousness, maybe convulsive movements. You can have single seizures, which will occur for no reason, and we can also have seizures that occur because of an underlying condition, which we're going to go over shortly. There is the small category of unclassified or idiopathic seizures. This actually accounts for about half of all seizure activity, and there is no known reason, no cause, and it does not fit to any kind of category. Now, let's go with what is epilepsy. Epilepsy is if someone has two unprovoked seizures, meaning like there's no fever, there's no brain tumor, there's no metabolic issue, and they just have a seizure. We're going to call this epilepsy. Now, what are secondary seizures? This is when there is a cause because someone does have a high fever. Maybe they had a recent hemorrhagic stroke. Maybe they're withdrawing from alcohol. Basically, in this situation, if we treat the underlying condition, all will be well. Now, there are three types of seizure categories, whether somebody has secondary seizures or epilepsy, it doesn't matter. There are three major seizure categories. The first one is generalized seizures. This involves both hemispheres of the brain that are going to become hyperactive in one moment of time. Then we have partial seizures. This is where a seizure will begin in just one little section of a right or left hemisphere. Interestingly enough, a partial seizure can very well turn into a generalized seizure. It's good to know the signs and symptoms of both, so whenever you witness one, you can actually report it more efficiently to the doctor. You'll have the language for it then. Okay. I think we're good there. So of the generalized seizures, there are 6 types I'm going to bring to your attention. The most common and most dramatic is the grand mal seizure. In this type of seizure, the patient loses consciousness and usually collapses to the ground. The loss of consciousness is followed by generalized body stiffening. We call this the tonic phase of the seizure, and that can last anywhere from 30 to 60 seconds. And then it is followed by violent jerking called the clonic phase. That will also last about 30 to 60 seconds. After which the patient will go into like a super deep sleep called the postictal phase or after seizure phase. During grand mal seizures, injuries and accidents are likely to occur, such as tongue biting or urinary incontinence or bumping of the head. So those ones are pretty injurious, I would have to say. Now, absent seizures are also known as petit mal, and this is where a short loss of consciousness occurs. It's just a few seconds, and there's no other muscular symptoms. So a person just looks like they're dazed or staring off for a brief period of time. The patient is most often a child, and it typically, it typically interrupts their activity time. They stare blankly, and then oftentimes you know that they might be having an absence seizure. Now, these seizures begin and end abruptly, and they actually are going to occur several times a day. Patients are not even aware that they are having a seizure, except that they may be aware of just losing time. Gosh, I feel like I have those all the time. I look at my watch and it's like 5 p.m. Okay, how did that happen? Absence seizure, y'all. Okay, myoclonic seizures, these consist of sporadic jerks, usually on both sides of the body. Patients sometimes describe the jerks as brief electrical shocks. When violent, these seizures may result in dropping or involuntarily throwing objects. Once again, just blame it on the seizure if you throw a plate at your spouse or boyfriend. I don't care. Doesn't matter. Sorry, myoclonic seizure. Okay, let's go to the clonic seizures. This is where you only have that repetitive rhythmic jerking that involves both sides of the body at the same time. There's contraction followed by relaxation. It's that pattern. Now we can also just have tonic seizures. This is characterized by a stiffening of the muscles. Remember, stiff drink is a gin and tonic. Tonic seizures are stiff, like a gin and tonic. Thanks, bartender. Atonic seizures consist of a sudden and general loss of muscle tone. We also call these drop seizures. Now, particularly in the arms and the legs, they will just completely lose all muscle tone and they're going to fall. This seizure is most resistant to drug therapy, and you will notice that the person oftentimes will wear a helmet. On to partial seizures. There are two types of partial seizures, and they are called complete partial and simple partial. Simple partial seizures, patients will actually report an aura. What is an aura phenomenon? This is where they will have a sudden sensation of like an offensive smell, maybe a sudden onset of pain, or they'll notice such vivid colors all around them or some kind of visual disturbances. This is once again called an aura, and for some patients it stops there. Like that is their only seizure activity, is this heightened smell, vision, and hearing. However, sometimes an aura can actually move right into a tonic-clonic seizure or a grand mal seizure. So it just depends, but please ask your patient if they have an aura before their seizure. We also have patients reporting something called a déjà vu phenomenon. This is where they feel like they've already been there or they're like repeating something, a déjà vu. That can also happen just before a seizure. Okay, let's talk about the main difference between simple and complex seizures, partial seizures. During a simple partial seizure, patients retain awareness. And then during complex partial seizure, they lose awareness. Now, they're maybe sitting upright, but they are not responding to you at all. That's kind of the big difference between simple and complex. And as you see number 3 there, a partial seizure can very easily convert to a secondary generalized seizure, such as a grand mal. Alright, so the doctor's going to tell you, place that patient on seizure precautions. What does that even mean? What are you going to do? Well, it means you are going to make sure oxygen is available in the room just in case you need it. You're going to have suction equipment. Whether you open it is up to you and your ability to conserve supplies, but I sort of evaluate my patient situation and I actually might open it. Just depends. You never know when you need it. But anyway, you're going to have IV access in your patient's arm. Please make sure that all 4 bed rails are up and that they are padded. And this either can be one of those pads that are commercially available and that fit on the bed to a T, or it could be you taking blankets and wrapping them around the bed rail. Please note, if you do that, don't wrap up the buttons where you need to like raise and lower the bed. That gets it's kind of in the way. I know new beds now have like foot pedals, but still, it's nice to be able to access the buttons when you want them. Okay, And be sure that unessential equipment can be easily moved away from your person. And absolutely at no time should you ever have a tongue blade at bedside. That is the old way of doing things. They do not do that now because it can break teeth, and the tongue blades can actually get swallowed by accident if a person bites it in half. So no tongue blade, please. You are going to make sure that you are going to give medications, they're anti-epileptic drugs, at the correct time. We are going to, what else was I going to say? Oh, because we know our patient is a risk for falls, occasionally some hospitals will place the mattress on the floor. I know, right? Big question to you is, can you delegate the task of setting up seizure precautions to your tech or to your unlicensed assistive personnel? Answer is yes, sirree. Now, I want to show you this of what seizure precautions and what seizure interventions you can do in the community setting. If a person actively starts seizing, now you're not going to have a bed rail available and a pillow to help cushion their head. You're going to have probably a jacket. Just put it under your head, under their head, and take their glasses off. I'm not going to read all of these to you, but this is a really good thing to do, a good thing to remember if you're ever in a restaurant, the movie theater, a concert, and somebody begins to have a seizure. You will be well trained and remain calm, and honestly just stay with a person. Hopefully they don't seize past 5 minutes. While we are in the hospital, I'll tell you what you need to do. You are going to make sure to document the body movements and other assessments, and we're going to delegate to our teammates to help protect our patient from harm. If you do have the ability to figure out if there is anything mentioned in the pre-ictal phase of somebody's seizure, that's like just before they have it, maybe they had an aura, maybe they had that deja vu phenomenon, that would be something worth noting and recording. So sometimes you may not have that information. Now, what are we going to observe for? You are going to note the date, the start time, the stop time, sequence and progression, like we went from a simple complex or simple partial seizure to a full-on, tonic phase seizure. It just kind of depends, but please make sure to document the progression. If it was the right arm, the left arm, was there bowel or bladder incontinence, and the post-seizure behavior called the post-ictal behavior. If a person has cyanosis during the seizure, do know that it is self-limiting. I would recommend, and the book recommends this as well, giving O2 during the post-ictal phase. Now, you may give somebody O2 if they're older, maybe critically ill or debilitated, but in general, they're not breathing anyway during that moment of the seizure, so you're sort of just wasting oxygen. Okay, so the primary nurse, which is you, is making observations and you're documenting. You're going to be reporting to the doctor. Please delegate it to your peers to put the hands on the patient and help them. Once they are able to bend a little bit, do roll your patient onto the side. You can accomplish that by bending one knee and rolling over to the side opposite of the bending knee. Honestly, you could roll over any size person by doing that. They just go. Do not restrain the arms. Let the arms move and legs move around as the person is seizing, but please guide them. You can rip a tendon. What? Yep, I know. Okay, I would like to tell you a one-size-fits-all treatment for a person who is having a seizure, but I said seizure, like Caesar salad, but it really just depends. So if our person is experiencing this metabolic disorder, maybe because they're having excessive vomiting, maybe they're hyperventilating on, say, a ventilator, or maybe they have excessive NG suctioning, and maybe we need to turn it down. It really just kind of depends, because all of those interventions, if I change one and that's not the problem of why a person's seizing, obviously it's not going to fix it. Let's see. Do you know that somebody can have a seizure from being under excessive emotional stress, maybe excessive caffeine consumption? I know, preacher preach. Or even alcohol withdrawal, which is the most dangerous withdrawal that a person can experience. That can be lethal and it can kill you. So anybody who is withdrawing from alcohol needs to receive the drugs down below. And yes, if we are having somebody who is healthy in the hospital and they do drink a lot, on occasion we actually will administer and give somebody a beer. Like, we will prescribe them beer for them to drink while they are in a hospital. I know, that's challenging for some nurses to administer alcohol. They say, I'm not a bartender. I get it. Okay, if we have high fever, maybe from an infection, treat that. Maybe if somebody has a stroke, in fact, if you have a hemorrhagic stroke, your patient's more likely to experience a fever. So a lot of times our treatment for that seizure will be to evacuate the bleeding or hematoma, stick a drain in it. Head trauma, or maybe anoxia, like they had a drowning accident, or some kind of asphyxiation, I don't know, rape or something like that. Or if somebody had a sudden withdrawal of epileptic drugs, they just kind of quit taking them for one reason or the other. Another reason is cerebral edema or increased ICP, intracranial pressure. All of those reasons, if you treat the cause, the seizure will go away. Okay, now let's pretend that we are treating the cause, however the person still persists to have seizures. If that's the case, we're going to slam the PAM, baby. We're going to give them lorazepam or diazepam. Those are benzodiazepines, and the drugs work wonders on somebody who is having a seizure in that moment. You're probably going to push anywhere from 2 to 4 milligrams for somebody who is having a prolonged seizure. And let me just tell you, patients are sleepy after a seizure, but if you go ahead and give them lorazepam, you can just forget getting any kind of successful neuro check out of your person. You have schnockered them. They're going to be passed out cold. So if that's the case, just give them a little bit of blow-by oxygen and kiss their forehead goodnight, because they're going to be out for a few hours, maybe longer than that. Another drug that we can give them, maybe not so much in the emergency setting, but we are going to give them a bolus of it to sort of coat and protect their brain from further surgeries, is IV phenytoin, or its cousin drug, phosphophenytoin. Either of those are going to be given following the PAM drugs. I actually have this picture here of David Brill. I found him on the internet. He's 15 years old. He actually had severe epilepsy, which means that he had several seizures per day. And after attempting multiple medications and not getting his seizures under control, his parents actually switched to giving him cannabis, which he smoked pretty regularly. He was then seizure-free on cannabis for 71 days. And yes, the authorities discovered this, and FYI, cannabis was not legal in that state at the time. So they told him to stop smoking, and unfortunately he suffered a severe, long-lasting seizure, such as, as I mentioned earlier, sudden withdrawal of epileptic medication. Marijuana kind of could be one if you're taking it for that reason. And when they have this severe, sustained seizure activity, it's called status epilepticus. And that is defined as seizure that's lasting greater than 5 minutes, like one seizure, or if they have multiple seizures, like little short ones, that last over 30 minutes. We want to consider this as a medical emergency, because if it's left untreated, we're going to have major metabolic disturbances. The patient's going to experience hypoglycemia, hypoxia, hypotension, and cardiac dysrhythmias. Hypoglycemia, hypoxia, hypotension, and cardiac dysrhythmias from all that seizure activity or prolonged seizure activity. Usually doesn't happen after one. So, all right, we are going to immediately try to push our PAM drugs, pass the PAMs, push the PAMs, what did I say earlier? Something like that. Give this patient these medications. We're going to grab an ABG to see if they have any metabolic disturbances that we can adjust. Maybe if they are under-ventilating, we can ventilate them appropriately. It just depends on what the ABGs are going to show. We are likely going to intubate this patient. If they are seizing and clamping their teeth down, like their jaw is locked, we can actually take this little device and open their jaw by inserting this device, and it opens their jaw, and then CRNA or maybe the respiratory therapist, wherever you work, who intubates people, they can actually stick it in there, even though the person's kind of seizing still. Here is a question for you. A nurse assesses a client with a, oh, I'm not going to read it to you. You read it yourself. You better pause the video because I'm about to show the answer. Okay. Here is my answer. If you need an explanation, there are notes that are hidden beneath this PowerPoint in the notes section. Here's another question. Please pause. Okay, here's your answer. Ta-da! Yep, airway. Drug therapy. Okay, so most of our anti-epileptic drugs need to have titers drawn. And what's a titer? A titer is a drug level that can have a normal range inside their bloodstream. And so we're attempting to see, are we within that range? Are we too high? Are we too low? And we may need to adjust the dose. Occasionally, we may be just at the top of the range, but our seizures are under control. So it's not uncommon for physicians to order 2 anti-epileptic drugs for a patient. They'll do combination therapy. We are going to make sure that our patients report any new seizure activity, because this is possibly due to tolerance or desensitization of the current medication that a patient is on. They sometimes will get too used to it and it's not going to work anymore. We are going to make sure that our patient is aware of any drug-drug or drug-food interactions. You can bet your bottom that a lot of antibiotics interact with our seizure medications. It's just so annoying. A lot of our blood thinners interact with seizure medications, so that's also annoying because you have to sit there and weigh the risk to benefit. And if you're ever questionable about that, run it by the doctor. And then antibiotics. Vitamin B6. That one's kind of a, wait, nope, scratch that. Scratch what I just said. Never mind vitamin B6. That's another medication. Sorry. Ask your patient to keep a diary of some of the side effects they notice. I'm going to go over some side effects in just a moment. But do encourage your patient to have utmost compliance, because the drugs cannot be stopped even if the seizure disappears. Okay? If we stop the drugs, we're possibly looking at status epilepticus, such as in my story of the boy, the slide before. All right, so keep taking your medications, even if they don't like it. What we usually do once we're switching is we wean them off one and we add another. One of the drugs I want to talk about is phenytoin. Phenytoin can be taken immediately following a seizure, or it can be taken as like long-term maintenance medication. But please know your person needs to have a negative pregnancy test prior to taking this medication, because it is a teratogenic. Now, phenytoin phenytoin has this nasty little side effect of decreasing insulin release. So our diabetic patients, yeah, they're going to have an increased sugar level. I know, we got to chase that around a little bit. So we might have to increase their doses of diabetic medication. Every single drug that is for seizures has a narrow therapeutic level, and we need to do titers frequently on our patient. The therapeutic serum level for our phenytoin is 10 to 20. We do consider greater than 30 mics per milliliter as toxic. So please double check these every 6 months or so, or if your person is new to the hospital and it is suspicious for phenytoin overdose, please grab a phenytoin titer level. Now, nystagmus is where your eyes kind of shake. This is actually going to be a side effect of this medication. Now, it is a clinical manifestation of, I guess, multiple sclerosis, but in our seizure patients, if you see nystagmus, you know it is a side effect of phenytoin. Another side effect of phenytoin is gingival hyperplasia. This is a very common side effect, and unfortunately, patients may need surgery to sort of reduce the excessive tissue growth over their teeth, or they may need to come off this medication. It kind of just depends. Why do we care if they have enlarged gums? Well, it puts them at a higher risk for cavities and dental disease. If you are giving this medication IV, do not give it with dextrose. It will precipitate and form these little crystals that are going to be going into the patient, which can cause major harm. So phenytoin is only allowed to be mixed with saline. Any anti-epileptic drug can cause pancytopenia, so please assess the CBC for anemia and leukopenia, which is low white blood cells. These are just some general comments. I've already mentioned monitoring the serum drug levels. You're going to double check that your patient is either negative for pregnancy, and if they're sexually active, make sure they are taking contraceptives. We don't want to discontinue this abruptly. Frequent oral hygiene and dental checkups is imperative due to, remember what that word was? Gingival hyperplasia. I might name my child that. Gingival. Yeah, okay, maybe not. Monitor their sugars because we are anticipating hyperglycemia. There is this little side effect I need you to be aware of. It's where their urine is going to be a little pink, a little brown looking, but there's nothing to think about it. Just inform your patient that this is expected, it's normal, and they are not bleeding. When I mention teach your patient to report sore throat, bruising, or nosebleeds, this is in direct correlation to that pancytopenia that may occur as a result of this medication. Now, this doesn't just go for this medicine, this goes for anybody with a seizure disorder. Please wear a medical alert bracelet. Here's a question for you. Please pause. Got your answer? Here you go. Ta-da! Here's another anti-epileptic drug, carbamazepine. This is used for refractory seizure disorders that have not responded to other anti-epileptic drugs. We can oftentimes use this for partial and tonic-clonic seizures. Do not let them have grapefruit juice when they are on this medication. That is a big no-no. Why? Well, this grapefruit juice actually increases the drug absorption by like 40%. So we are going to have a toxic level of this drug very quickly if we allow our person to have grapefruit juice. And as all my anti-epileptics do, monitor their white blood cells because we're going to have pancytopenia. Here's another one, valproate. We oftentimes will call it Depakote. Occasionally the doctors will say valproic acid. They're all the same medication. It is used to treat petit mal seizures, also known as absent seizures, where they stare off in the distance. Also, it treats grand mal seizures and really a mixture of other types of seizures. Hepatotoxicity is one of the possible adverse reactions, so please make sure to measure liver enzymes. Muy importante. Do not give it to somebody younger than 10, so you're not going to see this in our younger children. It also can have a teratogenic effect on our women who are pregnant. However, it's not as bad as someone who is on phenytoin. And you may even be wondering, well, what does a pregnant person take? They can't take valproic acid, they can't take carbamazepine, and they can't take phenytoin. Is there anything left for them to take? Actually, there is. They are usually placed on a medication called Keppra or levetiracetam. I know, how do you say that? Levetiracetam, also known as Keppra. We will see that medication. It is considered still a possible pregnancy category C, but it is the safest out of all of the anti-epileptics. Compliance with anti-epileptics is so important, so please encourage your patient to take their medications. There is an associated cost, so why don't you call social services to look for any other resources that can assist them. Let's evaluate their employment, because they may possibly be a pilot, they may possibly drive a commercial truck, and if this is the case, they will actually need vocational rehab. Yep, they are going to lose their jobs because a lot of jobs will not accept certain diagnosis because of the high risk to other people. Do talk to the family member and give them information that in the event a seizure occurs, they need to know what to do and when to call for help, generally when the seizures last greater than 5 minutes. Occasionally, drugs are not going to get somebody's seizures under control. So what can we do next? Well, not all patients can get this implant done. However, if somebody just has partial complex seizures, they can actually have a vagal nerve stimulator implanted into their body. And what it is it's actually going to be this little stimulator that's going to go into their chest, and it's going to run a signal to their vagus nerve. Now, if they feel a seizure coming on, they're going to wear this little wristband, and they're going to pass their wrist over their vagal nerve stimulator, and it's going to then send a signal to the vagus nerve, and it's actually going to interrupt, and it's going to abort their seizure. How cool is that? When we have that process occur, anticipate your patient to have a change in their voice quality. It's going to be weak, it's going to be kind of twangy, and they're not able to project. That is normal. Do not need to call anybody. We're going to treat it just like a pacemaker, so no MRI, no shortwave radio signals like microwaves or cell phones, and diathermy, which is actually kind of like a physical therapy thing that we can do with patients. They need to avoid that because that is going to turn our little device off, and I kind of think we need that on. But all it does is it just sits there, and if they feel that seizure coming, they swipe over it and it sends a signal to the vagus nerve. Neat. We do have some other surgical procedures that we can do for our patient. What is required is that the person is taken off all of their anti-epileptic medications. We're going to do extensive EEG monitoring, which is going to include video monitoring. They are going to do some baseline neuropsychological testing, which means we're going to check their IQ, get an idea of their memory, visual spatial functions, as well as language. And they, in this effort, are going to identify the epileptic region. And Now, when we identified it, we are going to go in and snip it. Right, we're going to do a partial corpus callosotomy. This has been very effective for those who have tonic-clonic and atonic or drop seizures. It's not common, but once again, it's very successful. I've seen this occasionally for people who have cerebral palsy. Okay? Here's another question. Let's see what you get on this one. Please pause. Okay, did you answer this? Ta-da! All right, this is the end of the Truman Show. Thank you, I know, thank you. The pleasure is mine.